is I would like to invite Dr. Nina Žakelj, who will be giving a talk on natural history study and will be providing with a 2-year follow-up of CTNNB1 cohort. Basically, she's the one who's going to tell you what happened in these 2 years when the doctors were taking the blood, the EEGs, the MRIs, and everything. So get ready for the good data. Yeah.
Sorry, I don't have pockets, so I can't have that. Hi, my name is Nina Žakelj. I'm a neurology resident from University Medical Center Ljubljana, and I'm also one of the researchers on the Dragonfly Natural History Study. And today I will present the preliminary results of our 2-year follow-up of the CTNNB1 cohort. So the Dragonfly Natural History Study is an international prospective longitudinal observational study of the CTNNB1 syndrome, and it's planned to run for 5 years. So why do we do it? We want to gather diverse data from different patient populations and different healthcare systems because we believe that this is how we learn. We want to develop a comprehensive understanding of the mental, physical, and social development of individuals living with CTNNB1 syndrome, particularly focusing on how the disease progresses and what we can expect from it in the future. And we're also trying to provide a baseline to compare the natural development to the children who are eventually going to be treated and are already getting treated with disease-modifying drugs. So you are able to get tested annually at established locations in Ljubljana, Slovenia, in Sydney, Australia, in Boston, USA, and now also in Quebec, Canada. And you're also able to switch between the locations if it suits you better. And then on top of that, you can also get tested at a new location every year based on where the CTNNB1 conference takes place. So far, we were doing that in Ljubljana in 2024, in Bilbao last year, and obviously this year we're doing it in Barcelona. So we like to spread out the examinations over 2 days because they are very intense for us and for you even more. And in person, what we do is the medical examination, the psychological examination, and the physiotherapy examination. And as most of you know, you get quite a lot of homework as well, and I'm sorry for that. But with this, we're able to get information on 15 different standardized questionnaires and other questionnaires that we have developed specifically for CTNNB1 syndrome. So this really gives us a lot of invaluable data on how your children are progressing. And we also use side devices. So Spila mentioned that briefly in her talk. These are wearable devices that track the way your child moves, the way they walk, their stride length, stride velocity. And the first year we got 20 side devices. We equipped them to 20 ambulant children, and now we're following them. And in the next 5 years, it will be interesting to see how their gait changes with time and how we can compare it to the children who are getting treated with gene therapy. So we're still accepting new participants. Anybody with a genetically confirmed CTNNB1 mutation can join, regardless of their age or their language spoken. But if your child does get selected to receive gene therapy, they will be excluded from the natural history study and they will be followed in the GAIN trial instead. So if you want to know more about the study, please visit our clinicaltrials.gov page. And if you want to apply, email us at nhs@ctnnb1-foundation.org. And with that, I'm going to present some data. As you can imagine, we have a lot of data, and it's a very small team that does this. So it's me, Laura, and Masha, who are bringing the papers around the world, inputting the data, refining them, digitalizing it. And if you get weird emails from us at 2 a.m. asking you to clarify some things or send some more information, we're sorry, but it's probably going to keep happening. So first, the demographic characteristics. We have 127 participants who have at least one visit and 56 participants who have done both visits. The mean age at visit was 6.9 years. And if you look at our age range graph, you can see that we have most of the children between the ages of 2 and 10 years. And we have less participants who are younger or older than that. So this is something that we want to expand. 48% of the participants are female, 52 are male, and they are residents of 25 different countries. Any guesses on which country is the most represented? Yeah? No, sorry. It's Spain, followed by the United States of America, Germany, Poland, and Australia. So we were able to digitalize and analyze 66 genetic results, and most of the variant types were frame shift on nonsense, followed by splice, whole gene deletions, or partial gene deletions. And in this cohort of the 66 patients, we had no missense mutations. And the most common location of the mutation was on exon 7 and 9, followed by some other who were less represented. 70% of the children were born vaginally, 30% were born with a C-section, and hypotonia after birth was noted in a quarter of the children. Feeding difficulties after birth were present in 34% of the participants, and NICU hospitalization right after birth was required in 16%. And the mean duration of the NICU hospitalization was 11.4 days, and the most common reason for NICU hospitalization was breathing problems, followed by heart problems, infections, and one patient had to be resuscitated. So the mean age at diagnosis was 3.6 years, and the mean age at the time of first clinical symptoms was 6 months. So because these are mean values, we can't simply say that it takes 3 years to diagnose CTNNB1 syndrome, but we are very interested in this diagnostic gap, what happens in the meantime, and how we can try to reduce it. And this is something that we will look into in the future. So the most common first clinical symptoms reported were motor symptoms, and this is an umbrella term that we use to encompass motor developmental delay, missing motor milestones, hypotonia, and poor head control, followed by global developmental delay, so speech, and feeding and growth difficulties. 57% of the participants reported taking at least one medication, and the most commonly reported medications are listed here. So by far the most commonly reported was melatonin, Botox, laxatives, and then also baclofen and risperidone, followed by some other medications. And I thought it would be interesting to see what the reason for taking medication was. So what's the most common reason that your child needs medications in the first place? And here is an indication-based chart that shows that spasticity or dystonia is the most common reason that these children take medications, followed by sleeping problems, behavioral problems, constipation, seizures, and neuropathic pain. In regards to motor milestones, standing with assistance was achieved by 85% of the participants at a mean age of 2 years, and the latest age at which they were able to achieve this milestone was 6 years and 6 months. Walking with assistance was achieved by 82% of the participants at a mean age of 2 years and 3 months, and the latest age at which they achieved it was 5 years. Independent walking was achieved by almost a half of the participants at a mean age of 3 years and 2 months, and the latest age at which they started walking independently was 8 years. And climbing stairs, here we talk about independent climbing of stairs, so without using banisters or holding onto hands, was achieved by 32% of the participants at a mean age of 4 years and 11 months, and the latest age at which they started climbing stairs independently was 10 years. So if we take a look from a different perspective, so like I said before, standing with assistance was achieved by 85% of the participants at 20 months, but we wanted to see what happens later. So is late acquisition still possible, or is that something that we cannot expect? And if you look at this graph, you can see that at first the curve is sloping upwards, and then it kind of just grows straight. And we were interested to see what happens there in that straight line. And we found that after the age of 5 years, 2 additional patients started to stand with assistant. And after the age of 6 years, only 1 additional patient was able to achieve this milestone. So based on our data, the probability to achieve standing with assistance after the age of 5 years is 12.6%, and after 6 years, it's 8.3%, which makes late acquisition possible, but not possible, but uncommon. With walking with assistance, you can see that the graph looks kind of similar. So it was achieved by 82% of the patient, and the mean age was 24 months. And after 5 years, no additional patients achieved this milestone. So based on our data, late acquisition is not really expected. Here you can take a look at a graph that analyzes independent walking, which, like I said, was achieved by half of the patients at a mean age of 36 months. And after the age of 5 years, we observed this milestone achieved in 4 patients, and after the age of 6 years in 1 patient. And the graph looks similar. So the curve is sloping up, and then it kind of goes straight again. So the probability of achieving independent walking after the age of 5 years is 9.3%, and after 6 years, it falls down to 3.1%, which again makes late acquisition possible, but not very probable. And the graph looks different when we looked at climbing stairs independently. So like I said, 30% of the patients were able to achieve this milestone at a mean age of 55 months. And compared to the graphs I've shown before, we don't have a straight line happening. We have a curve that just keeps sloping up, which means that late acquisition is common. And based on our data, after the age of 5 years, the probability of achieving this milestone is 19.6%. And after 6 years, it's almost 80%. Of course, in children who were able to at least walk before. So we think that this is because higher order motor refinement may continue beyond the age of when basic milestone acquisition plateaus. And why we're interested in it, so we're trying to identify potential sensitive functional endpoints for therapeutic interventions. So if we treat a patient with gene replacement therapy that's located at the straight end of the graph, and they start acquiring those milestones, we are more confident in saying that the acquisition of this milestone is related to the therapy and not to the natural development of the disease. So for example, if we start treating patients at the age of 6 years who have not yet started independently walking, and they start walking, we are more confident to say that this was connected to the drug rather than the natural development. And we could use the same marker for older patients, so independent stair climbing for patients who are older than 10 years. A little bit about speech. So the mean age at first spoken word was 27.2 months. The youngest patient to start talking was 5 months old. The oldest was 9 years old. And I just found out during the examinations 2 days ago that the youngest patient who started talking is now performing in theater productions of Hamlet, which I find very impressive, so good job. But still, 96% of the participants have some sort of a speech disturbance. And out of those, a quarter have no verbal communication. And in the others, the problems are related to poor vocabulary or dysarthria, so trouble articulating. And if we look at the graph, which is similar to the ones I've shown before, you can see that the curve keeps sloping up, which means that late acquisition of speech is still possible. And that's different to the motor milestones that I've described before. The second year, we started asking about spinal health as well. 75% of the participants had a spinal cord MRI performed, and out of those, more than a half had some pathological findings. Most commonly tethered cord, syringomyelia, fatty phylum, spinal lipomas, hemivertebrae, or a medullary cyst. And in the future, it will be interesting to see if those children get surgery, and if they notice any changes in spasticity, in urine retention, and other problems that can be present in tethered cord syndrome and CTNNB1 syndrome alike. The second year, we also introduced a new questionnaire, which is the sleep disturbance scale for children, and it assesses sleep quality in children over different subdomains. The first one is disorders of initiating and maintaining sleep. It asks about sleep duration, sleep latency, difficulty falling asleep, and so on. And it basically describes an insomnia-like phenotype. The second subdomain is sleep breathing disorders. It asks about sleep apnea, snoring, breathing problems. The third subdomain is disorders of arousal, which asks about sleepwalking, sleep terrors, and nightmares. Then sleep-wake transition disorders, which asks about hypnic jerks, rhythmic movement disorders, hallucinations that are present when falling asleep or waking up from sleep, sleep-talking bruxism. Then disorders of excessive somnolence, such as difficulty in waking up, feeling tired when waking up, sleep paralysis, daytime somnolence, sleep attacks, and bedwetting. And the last one asks about falling asleep sweating and night sweating in terms of sleep hyperhidrosis. So we analyzed the mean values of all different subdomains, as well as the total score for sleep disturbance scale in 83 patients. And what's basically stands out the most is that in the insomnia type phenotype, so in the disorders of initiating and maintaining sleep, the participants scored a higher mean score than 90% of the population, which is clinically significant, and it means that these children have a clinically significant insomnia-like phenotype. And in other subdomain tested, for example, in sleep-breathing disorders, the participants scored worse than 57% of the population, but that's not enough to be considered clinically relevant. In the other ones, the mean scores corresponded to a normal to mild borderline range, and in the sleep hyperhidrosis subdomain, it corresponded to a normal range. And then if we look at the total score, the mean total score was 43.6, and the cutoff value for clinically significant sleep disturbance is 39. So based on our data, we can say that children with CTNNB1 syndrome do have a clinically significant sleep disturbance that is mostly driven by an insomnia-like phenotype. We wanted to see if there is a difference in scores in children who take sleeping medication compared to those who don't, and we didn't find a significant difference between the two cohorts. So this doesn't necessarily mean that the sleeping drugs are not working. This can mean that the children who are now taking sleeping medications were doing worse before and are now catching up in terms of sleep quality to their peers. And this is why we're going to do the same questionnaire every year. So we'll see what happens with the children who are now in the group without sleeping medications and maybe start taking them in the future, if the sleep scores change or not. And also what I will be personally interested in finding out is whether the sleeping scores change with time and as the kids grow older, because I think that this is something that parents report, but we weren't able to analyze it yet because we only have one time point. And I will end with what I like to start with during my examinations, because this is the part that I dislike most, and I think you guys dislike this the most as well. So every year we ask about your treatment priorities and your risk acceptance. And in the treatment priority section, we ask you, so if there was a magical drug with which you could pinpoint which problems in your children you would most like to treat, what would those symptoms or signs be? So we give you options of 7 different domains: intellectual disability, speech, motor, behavior, sleep, and feeding problems, and seizures. And we ask you to rank them in order from 1 to 7 based on how you prioritize them. And the analysis we did is based on the distribution of priorities, so how many times you put a certain domain in your top 3 list of priorities. And based on that, we found that your highest priorities in treatment are intellectual disability, speech problems, and motor problems. Behavioral problems are your medium priority, and your lowest priorities are sleep, feeding, and seizures. And then risk acceptance. So every year we ask you about how accepting you are of certain risk happening during the clinical trial. And the clinical scenarios we present to you are allergies, liver problems, cancer, treatment failure, and ultimately death. And we ask you to give us a number from 0 to 100% based on the acceptance of the risks involved. And if you look at the clustered column, you can see that so no acceptance was most commonly reported in risks related to death outcomes. Low acceptance was reported in risks related to cancer. And moderate acceptance was reported in risks related to treatment failure or liver problems. And of course, higher acceptance was connected to risks of treatment failure and allergies, which is something that we anticipated as well. Then in the end, I would like to thank all of the children and the families. We don't take it for granted that you travel every year to see us. We are learning from you, and we are really grateful that we're able to do so. But I would also like to thank all of the doctors, psychologists, and physiotherapists who are working on this project. And specifically, I would like to point out Laura, because she's the person who's making sure that this ship doesn't sink, and it's been close to sinking a few times. So Laura, thank you, and thank you for your attention.